see. And then,
You may want to change it again. You have it back on the.
yeah, I'm doing that. It's there. It's okay. Yeah. Okay.
Perfect.
Looks good now.
Thank you.
So I think Sabath can get us started.
Hi everyone. Good evening. I'm Sabat, the director of the Boston Congress of Public Health Thought Leadership for Public Health Fellowship. And I'm Sabath. I'm joining from Nigeria. So I would like some of us or all of us to put in the chat and in the comments where we are joining from, our name, our location, and possibly what time is it. It's 6 p.m. here in Nigeria. So I'm imagining some of us joining from Far East Asia. We should be around 11 p.m., 12 midnight. So it's good to have everyone on board. So without further ado, today we are going to be having a live webinar by one of our fellows. So this is something we are trying out newly. So we want to give our fellows a chance to test themselves in podcasting. And you, the audience, you would provide feedback with your comments, with our mid-webinar surveys, and even after the end of the webinar so that we can have that good feedback to see how we can improve Sade's thought leadership. So that's why we are here. I would like to go to Dr. Cersei and Dr. Candice to introduce themselves as well. So Dr. Cersei?
Yes, welcome everybody. It's so nice to see you on here. We really appreciate your time being with us today. My name is Dr. Cersei Lecomte. I'm co-CEO of BCPH and co-editor-in-chief of the Boston Congress Public Health Review. We're very proud of Sade and her upcoming live podcast that she's presenting today. About halfway through the webinar, I'm going to be posting a pulse poll for everyone. So please, if you have a moment, just complete it so that Sade can get some feedback about how you're feeling about her presentation and what she might be able to improve on. But without further ado, to give Sade enough time, I'd like to hand it off to my colleague.
Yeah, thank you so much for that, Dr. Lecomte. So I'm Dr. Carpenter, so other Chief Executive Officer and Chief Strategy Officer for Boston Congress of Public Health. Very excited. This is number 2 of the live podcast showdowns that we're having for BCPH. So if you haven't had a chance to check out the other one, it is on our YouTube channel, so you can find it there. And this is a whole series, so there'll be multiple ones. There's another one this week, actually 2 more this week, I believe. So make sure that you check all of those out, and definitely feel free to send us emails at communications@bcph.org, because we want to continue to do that and make it so that we can have more podcasters within the public health and the social justice space. But without further ado, I'll hand it back to you, Sabah.
Yeah, thank you so much, Candace. So, Sade, within the next few minutes, will be taking us through health disparities in Kenya through a Muslim lens. I'm looking forward to this conversation. And just like we explained, we are going to be having pulse polls for us to get feedback intermittently. And if you have any questions, kindly utilize the Q&A, and also the chat box will be there to recognize those questions and take it. So Sade, if you're ready, we are ready for you.
All right. Thank you, everybody. And it's 8 p.m. in Nairobi, in Kenya, and it's been a challenge getting somebody to attend at this time. So for that reason, it's a solo. I'm really thankful to BCPH team for this great opportunity. And my podcast series is Muslims for Health, Leaving No Kenyan Behind. And this is the inaugural episode. I don't know how many of you know much about Kenya or have been to Kenya. Probably what you've heard is it's a beautiful country, a great tourist site, as well as that we are some of the fastest runners on track. So without also everyone saying without much further ado, let me start with this. And my podcast, wait. Uh, First, I don't know how many of you is it showing on slide mode or not? Is it?
It
Yeah.
was showing before, now it's showing there you go. That's
Okay.
perfect.
Okay. Great. So this is the first of many, I hope, episodes, and we shall also, based on what we discussed today, draw lessons from the Islamic medicine golden era. We shall also look at Sharia compliance in healthcare, Ibadah-friendly hospitals, the field experiences. We want to look at also environmental justice from the Islamic perspective and how to augment the current medical education with Islamic bioethics. So I hope that many of you will keep up because these are subjects that not many people are familiar with, right? For this episode, I shall divide it into three, and one of them is to describe or to characterize who are these Kenyan Muslim population. How many are they? What's the ethnic, racial composition and geographic distribution? Then we shall go to the actual health disparities that we are concerned about and what are the root causes or related factors. And finally, I hope you'll stay long enough to review some case studies that will enhance your understanding on this. All right. So what do we mean by health disparities? It's a word that's not commonly used, I guess, but it's mainly, what's the lack of similarity or equality, whatever is substantive difference. And this difference is actually preventable. What we're looking at, the preventable factors that could actually reduce those disparities. And we're looking at those that affect people due to maybe their race or their ethnicity. And what exactly, which aspects of health disparities? We're looking at access, we're looking at coverage, and also outcomes and quality. And all this, for us, it's through the lens of the Muslim perspective. Other measures of disparities could be inequalities or inequities, but here it won't allow us to go into too much depth. But I hope by the end, we will all be on the same page. And studies have shown that there are various factors that can affect these health, the determinants of health, the social determinants of health, and these can be, from housing to education status to public transportation infrastructure, you know. So we shall be looking at some of them during this episode. But secondly, we need to understand who are Muslims. What do we mean by Muslims? After all of us have all these preconceived ideas. There might be misconceptions. There might be some truth in them, right? After all, I mean, Muslims or Islam is actually the most widely publicized religion, but not necessarily positively, right? It's like we're known as to be the terrorists, we're maybe the ignorant people, or we're just undermined. And also it's good to understand that if we are bashed and we have all these negative adverse effects, why do these Muslims continue clinging to their religion? After all, it's the most strict. It seems that some people see it's very discriminatory. Maybe is it against women? Being Muslims, those who are becoming are told, okay, no more parties, no more alcohol. So, and you come back late at night, and then what? You have to wake up at 5 in the morning and you have to pray 5 times. Is that really practical? Is it really easy? And then fasting, staying hungry the whole day, no food, no water, you know what are these Muslims about? And For those who can afford, they're supposed to go for Hajj, go for pilgrimage. And for the women, that they actually have to accept that their husbands can marry up to 4 wives. Is that really thinkable, acceptable? And the husband is allowed to, punish his wife if she's disobedient. Does this really, how does it feature on you as a non-Muslim? But now this is a whole population, not just Kenya, but elsewhere. But we are zeroing in on my country. So in Kenya, Islam is actually the oldest religion from about the 7th century. Basically, immediately after Prophet Muhammad was declared, prophet, then people had to escape, run away from persecution from Mecca, and they fled and they went to Ethiopia. And so along from Somalia up to Mozambique, they would come and settle that early. And also, Kenya so has all these religions, Christianity, Hinduism. Christianity came around the 19th century. Hinduism came around the late 19th century. And then we have all these Kushites. So Kenya, you can say maybe it's people who came from outside who really constitute Kenya. It's a very rich, diverse ethnic composition. Even we have genetic studies that prove that the people here are a mix of Arab, European, Asian, very diverse groups. So we have like the Arabs, Somalis from the Kushites from north. Then we have the Nilotes or Sub-Saharan from the west, and Sudan, Egypt, and then we have the Bantu as well coming from south, going to the central parts. So basically, the way the Muslims are is like we're told that despite being some of the oldest Kenyans, that we are still to date only 10 to 11%. Like when they first did this census in 1962, they reportedly told us that, yeah, you're 6%. And then each year, maybe they increase us by 0.5%, or every 10 years. But we actually we don't agree with this politics of census. But we believe that we are likely like 25% of the population, and that it's just that we are not in control of how the census is done. All right. But now we have like that this gives a history, the entry of how the Muslims came. So as I said, from the 7th to 10th century, they came from Arabia and they settled along Somalia's sides. Then we had a second wave on the 13th through 15th century. So still from the Middle East. And this we had, Syria, Oman, and even Yemen, and they also settled along the coast. So these ones settled mainly along the coast. And then gradually we had others, the third wave, still from Middle East. And then it's only from mid-1800s that then the Asians started coming. And these were economic migrants, all right? Even the Arabs, they were doing trade along the coast, from Lamu to Mombasa. And then we had Asians who came first. First, they settled at the coast. But then when the white settlers started building the railway, then it brought in more Asians to come into, to settle. And that's when, with the railway, as it progressed, then like at that time, the Muslims from the coast were the most literate. So, and then because they were early, they used to trade and move inland. So even the colonialists would hire the Muslims from the coast to guide them through. So more Indians came in, and then they also now spread more inland. And then finally, the last wave were from South Sudan, and these were soldiers. The South Sudanese were known to be very brave and fearless. So they were hired by the British colonialists to fight in the First World War and in the Second World War. And then at the end of the World War, the British now reluctantly settled them in Nairobi, Kibera, and also other parts. But that's another story that we shall get into. So who is a Kenyan citizen? All right. So we've seen that we have all these people who've come in, including the indigenous, as I said, from the Kushites, Nilotes, and Bantu. And all of them now, when 1963 is when Kenya got its independence. And at that time, then the law was that anyone who had been born in Kenya after 1963 or has parents born in Kenya is a Kenyan, all right, just outright. So those that happen to be in Kenya within the borders at that time were supposed to be Kenyans and their offspring, all right? And then also the Kenyan Constitution awards any Kenyan has a right to the highest attainable standard of healthcare, all right? So this here is now like the Kenyan population distribution. It shows like what you see is green, the religions of Kenya. What's green is representative of the Muslim population. It's the dominant, the areas with predominantly Muslim population. Then the other colors are the other religions. Basically, you have religions, everybody, all faiths are scattered across the whole country. However, now that color coding is where they dominate. All right. So we can see like the top graph shows Garissa, Wajir, and Mandera having over 90% of their populations are Muslim. All right. Then we have Kwale and then Tana River, Isiolo. Those ones, it's also 70% and above. Then Mombasa, where I come from, where you see the tusks, it was previously very high dominance, but it's now more cosmopolitan place. So then the bottom graph, it just shows the, the heat map. So you'll see the blue is Somalis are like half of the Kenyan population. And then the other tribes are, they're listed there. But these numbers are according to the Kenyan census, which we're not too sure of. We take them with a pinch of salt. All right. And then here it just shows that the same graph, maybe I don't need to go much. So this one, the last one, this is on describing the populations. And so we can see Mombasa, which had about 37% Muslim. The graph doesn't look, it looks like it decreases up till the age of 15, and then those age 20, 24 are high, bigger, larger populations. This is because Nairobi, the one on the right, has the same structure. So these ones are representing migration. They're very popular cities, and so you have a lot of in-migration, and that's why you see like the economically productive age is bigger than the under 15s, 15 years and under. But Kwale, Mandera are typical of many of the other counties where you have like under 15s from like maybe half of the population. So let's see. So I think, and this one just shows the ethnic distributions. We looked at Somalis, and Somalis are mainly, as you can see, along the northeastern provinces. Then we have at the coast, you have the Mijikenda and Swahili, and then we have the other tribes who are depicted there. So I don't know if there are any questions on the population numbers and population ethnicity, as well as the religious landscape that I've just described. Are there any questions so far?
Not
I
that I
said,
see, Sade.
okay.
All right. All right. Wow. That means I'm very clear, right? Anyway, okay. So now we're going to go into the health status. Yeah, because I mean, there's so many areas I looked at with regards to health status. We want to look at in what way does the health status of Muslims, where it looks like it's different. And I'm projecting these maps because this is how we're going to be presenting the health status. So if you see the color coding that on the right, northeast, then you know that it's mainly the Muslims who are affected. And here we can see this is from the Kenya Demographic and Health Survey. So each of these 6 maps is depicting, a certain measure. So the first one, we're looking at secondary school, those who attained secondary school and above. And you
Sade,
see like northeast, yes,
may I suggest,
yes,
we do not see your screen, your slides at this time.
okay. Uh-huh. Can you,
Um,
do I unshare and share?
Okay, I see them now. Thank you so much.
Okay. Can you see now this one of
yes,
six maps?
Yes, yes.
Thank you.
yes.
Thanks for letting me know. Yeah. So I deliberately showed for the previous, which you could see now the racial, the ethnic. So the Muslims are, like the half northeast and the coast. And that's where you can see secondary school and above is less than 7%, at that, okay, of the whole population. Then health facility deliveries, it's recommended that for best birth outcomes, they need to be delivered in health facilities. But you can see again, the reds means less than 25% of women give birth in health facilities. Again, in the Muslim predominant areas, more so than the other. And even coast, at least in this, it has improved somewhat. In terms of socioeconomic status, again, we can see it's only the bottom that has better socioeconomic status, the socioeconomic quintiles compared to the other parts. And then here, when we look at proportion that are married, again, you can see the fourth, that's the second bottom on the left. The Muslims predominant areas are more likely to be married, although this one is not saying what age, but the middle one is saying age at first marriage is below 18. That's early marriages, which in terms of health poses a lot of risks, right? And so for here, we can see again, the Muslim predominant areas is where you have, more than 60% are married before 18 years, all right? And then the last one on the right, it's depicting those with higher births more than 4, 4 and more, maybe up to 10 or 15. And again, you can see northeast and a bit of coast. That's a problem, right? So this is from the periodic population-based surveys. That's what we're seeing. And then now this is, I think, yeah, this is also showing the contraceptive prevalence rate and the total fertility rate. These are from the census, the population census, and they give again the same picture that they're distinct differences that contraceptive prevalence rate is less than only 2 to 3% for Wajir, Marsabit, Mandera. These are Somali predominant areas where more than 90% are Somalis. All right. Then at the coast, Lamu, Kilifi is slightly better, 36 to 55. And, in the central is where the prevalence of family planning, modern family planning uptake is really high. So when you see that it's really high, then you wonder how they continue being the dominant, that the people from Central Region, according to the census, comprise 20% of the population. And consistently, every time we do census, they still claim to be the largest population. And yet, how is that possible if their uptake of contraceptives is really high? They're like the model that others are supposed to follow. And the other regions where you can see it's so poor and they're multiplying in big numbers with polygamy as well. So how is that possible that those numbers are still, we're still 10 to 11%? So the other one is total fertility rate, the map on the right, and it shows that, again, Mandera has the highest. That is 8 children per birth, per woman, 8 births per woman. All right, it has the highest. Wajir has 6.8, against a national average of 3.4. So, I mean, these to me is you need to, look at the census vis-a-vis the fertility rates and birth rates to really validate those numbers. So the other issue is that the disparities is about infrastructure. All right. What contributes to the Northeastern, especially, to having, you know, poor key performance indicator performance. One reason is the access to health facilities. In Kenya, when you do the census every 10 years, the numbers are really critical because all the planning and budgeting by the government is based on the population per, per county. So it's in the best interest of people to get as many to increase their population, right? But now here, when you look at Mandera, the Northeastern, they're really sparsely populated. Because we could see the population is about 800,000 in Wajir, in Mandera, compared to maybe Central Province. It's like they have 20%, but their geographic area is so small. But they have very good coverage in healthcare. Whereas in Wajir and Mandera, Northeastern, you have to walk for miles. A woman has to travel for miles to access any health services. So here, the yellows is where you can see is like 1 to 2 health facilities per 10,000 population. So why are we surprised, at the poor health-seeking behavior? Then the other map on the right also shows that there's poor antenatal care coverage in Northeastern and compared to the other locations. But it's for antenatal care also, it's not just about infrastructure. It's also about the health-seeking behaviors because the the people in Northeastern, they are not keen to be pushed to adopt family planning. All right. So they are reluctant to go. They trust the midwives, the local midwives, and so many of them tend to give birth at home, if possible. And only if there are danger signs will they rush. So it's access and also their own beliefs. And these are data now from the routine health monitoring, routine health management information systems. The previous ones were from the census and from the Kenya demographic and health surveys that are done every 5 years. But now this is a recent publication that use now the routine health information systems, and it more or less gives a similar picture of the differences that Northeastern and maybe Coast may have less suboptimal indicator results, right? Same thing, this is about family planning. You can see the stark difference. And even when it comes to full immunizations for children under 1 year, we also see the same, that Northeastern and those areas have a lower immunization coverage compared to the other counties. Are there any questions here? before I move to, that was now just on the health, health outcomes. Just comparing it to the geographic distribution by religion and by ethnic groups.
I don't see any
Anyone?
questions in the chat.
All right,
Oh,
thank you.
wait, sorry, I'm sorry, there is a question.
Okay.
Marion, go ahead.
Mhm. Yes.
We're waiting for them to put their question.
Okay.
1 second.
Okay.
Here we go.
So yeah, hold on, Marion. We will try to see if we can unmute you so you can speak your question.
Okay.
Okay, I will unmute her now.
Go ahead.
Hey, good afternoon.
Good afternoon, Mariam.
Yes, yeah, good afternoon, Dr. Abdullah. Thank you for your presentation. My question is regarding the pregnant women that have to walk miles from their homes to the closest health centers. Does Kenya as a country, does it have any community health workers working in those remote areas where women who might need pregnancy services, they are able to get connected with the CHWs? They call them CHWs here in the US. Do they have
Right.
community health workers in Kenya? Thank you.
Yes, thank you. That's a great question. Yes, Kenya does rely a lot on the community health workers. We have community health promoters. We have mentor mothers to try to increase access to health services. They do. But, it's all about partners. Yeah. Because in these areas, the northeastern, they've been relying a lot on UNICEF. UNICEF has been the main supporter of reproductive, maternal, and child health interventions in those areas. Whereas when you look at the other parts of the country, they have, they're overwhelmed by partner support because you have USAID, we had still the UN agencies, and we still have also a lot of other NGOs that support. I think maybe first it's the comfort, the semi-arid areas are more difficult areas to work in, but also HIV. Because of HIV prevalence being higher on the western side, in the Nairobi, in the city, maybe in Mombasa. So HIV funding is what has pulled people to the other areas. And in the northeastern side, traditionally it was always assumed, oh, Muslims don't get HIV. Muslims have very low prevalence. So even when they would do a lot of surveys, they would tend to, exclude northeastern region from the surveys by just assuming that first it's very difficult to conduct the logistics and the expense, the additional expense. So it was like forgotten. So we're not sure about, the HIV thing, but HIV has been the main driver of funding to all these other areas. So I know like you'll find 50 mentor mothers in one county in the western side. And that same in the northeastern, maybe you have 5 or 10. Yeah, but at least the Ministry of Health has tried to now address that shortfall this year. All right, Mariam?
Yes, thank you very much.
Okay. Any other question? Yes?
So I have a question for you.
Yeah.
You just mentioned about HIV and this perception or belief that Muslims in Kenya do not have it. I was just wondering if that is perhaps a reflection of low testing rates, or is this based on something else?
Yeah, I agree. I wouldn't say Muslims, but I say like in the northeastern Somalis.
Okay.
All right.
Because you mentioned
it's
that
more.
you said the word Muslim
you're right.
specifically. Yeah.
I did. But more in the Somalis. I think they looked at also Somalia as a country. It had very low prevalence for the longest time. Yeah. So definitely it's about testing. the uptake is not so good. Even when we have a mother who's bleeding, for example, she's having postpartum hemorrhage, and to save her life, she needs blood, right? So like the health workers are going to mobilize their relatives, to donate blood. And many will come forth. I'm donating, but don't test me. I don't want to know what you test the blood, and whatever the results, I don't want to know. All right. So there is that fear. So at least antenatal care is helping women to access testing. So the men is like they are the proxy. If the wife is negative, so he assumes he's negative, right?
Okay.
But it's been the main missed opportunities, Northeastern compared to other counties. It's like very high missed opportunities because you have antenatal care attendance. Every first visit should be tested. But there you'll find, nope, they are opting out of testing.
Fascinating. Thank you for sharing.
Mm-hmm. You're welcome. All right. So we continue. Shall we continue? All right.
Yes, please.
I assume silence is consent. All right. So there is this InfoTrack research that in 2023 they developed this performance index, to assess county government performance. All right. So they were assessing on all these areas. So it's like all counties, all constituencies and wards. And so they were covering, all these functions, right? To see how well the county was implementing all these aspects of development, right? And so then an average so each measure was, assessed. Every count was assessed on each measure and then rated, and then as an average, each function had many different components, okay, which I will not go into in this session. We're just looking at the overall picture. So, yeah. So then overall, when they looked at all the functions, education, got the highest ranking, all right. And then whereas public participation got the lowest, and then overall ranking for all the counties, well, it's like more or less like half. And so we can see like health was, like average, like 49% in terms of ranking, okay? So this shows now we want to look, of course, health. What was the health performance, the ranking? And we can see like Northeastern, not surprisingly, is the lowest, 46% compared to Rift Valley, and Central. Those are not surprisingly, you expect that those are where first the presidents of Kenya have been from these two regions, okay? Well, first one, Jomo Kenyatta, Central. Then we had Kibaki, Central. Then we had Uhuru Kenyatta, Central. So let's say, and then we've had Moi, and now we have Ruto, they're from Rift Valley. So that is expected that they would be doing better. Nairobi, although it's the capital city, it's actually it's a mix of slum areas and, high end. So, that's why we get this kind of picture. But Northeastern, as we have seen, it's actually not been doing too well. And what we can see from all these, the top 25 counties, we don't have a single one from Northeastern. All right. You can see, because I think now I've talked enough about Garissa, Wajir, Mandera, Marsabit. You don't see them here. They're ranking poorly. But in terms of coast, where they also have a substantive proportion of Muslims, we do see Mombasa, we do see Kilifi, and Kwale is the other one that seems to be doing much better. So when we look at the education, again, surprise, surprise, Nairobi is doing a bit less, lower than Northeastern, even though in terms of education infrastructure, Northeastern is actually quite poor. But as I said, Nairobi, it's the big slums. It has the biggest slum in Africa. So that's not surprising. And again, when we look at the top 25 counties, we don't again see we don't see Northeastern again, right? We don't see Mandera, Garissa, Wajir, Marsabit. We see, let's see, even Coast doesn't feature that much, right? Yeah. So even when you look at the scores for those, they're lower. Okay. Then when we go to the county tracks, this is the overall aggregated county. Let's see. Wait, where is it? Yeah, this is the county overall. We can see Nairobi is doing a bit worse than Northeastern. I think it's because of in some areas, Nairobi wasn't doing too well. But anyway, this is just telling you these are the social determinants of the social determinants of health, that they are the ones that if the education is lacking or infrastructure is lacking, roads or whatever, then obviously the health indicators will be impacted. Over here now, it's just comparing now the health indicators for different measures. So coast is the orange, or I don't know, brown. Mombasa, Lamu, Kwale, Kilifi are coast. Then yellows are northeastern. So you will see that across all the indicators that the northeastern is doing worse in terms of maternal mortality. Maternal mortality is at the bottom. You can see that Garissa had, where is it? 641. 641 deaths per 100,000. Then you can see that even Kilifi, which we saw before, is not doing too well. In terms of birth notification, just registering that child's that they've been born and they need a birth certificate. Even that's a challenge for Northeastern. It's about access. You have to go travel far to go register your child. And that's the beginning of your recognition as a Kenyan citizen. And yet they're having challenges just registering those births. And remember, they have high total fertility, 8 births per woman, and you're not able to register all as you should on time. And so births in facilities, you can see 49%, lowest in Wajir, compared to 95% in Mombasa. So Mombasa is, at least it has access. Then percent married at age 15 to 19 from the bottom, you can see much higher in Northeastern compared to, let's say, Mombasa and Kilifi. Under 5 mortality, same thing, much higher in Northeastern. Life expectancy for males and females. Females is higher than for males. But when you compare with Northeastern, it's not as good, right? So these are the same things that I've already presented, just showing graphically, and you can see the graphs, the distinct difference. I think you're all experts at this time, right? So sorry. So yeah, let me stop there. Any questions before we go to our case studies?
I'm checking. I don't see any questions.
Okay.
But I
Comments,
think
you don't have to ask questions. Even comments are most welcome. All right, no problem. I'll continue. Thank you very much. Now I have 3.
one. We did
Yes.
have one question.
Okay.
Khadija Mohammed asked about life expectancy due to nutrition. And I think what I'll do is I'll have bring them off so they can actually ask more.
Okay, great. Yes, Khadija?
Yes, so I wanted to ask, is their life expectancy affected due to nutrition?
Hmm. Yeah, because this is at birth, right? Um, I think the mother's nutrition status, yeah, is may not may be it may affect, right? In terms of the maternal weight, um, also the breastfeeding, infant feeding practices. They do have whatever they do influence, but I would have to read more to be able to answer this question better.
Okay, thank you so
All
much.
right. Thank you.
Thank you.
That's a good question. Okay. I can see why you're asking me about nutrition. All right. So we are now going to Nubians. We have 3 case studies. So one of them is about Nubians in Kenya and the politics of numbers. Okay. Then the second case study will be about, uh, I've tried to capture different Muslim communities. So one of them, Nubians are in Nairobi, Kibera, and then curbing drug relapse are the coast, and then we'll go to the last one on contraception reviews, and this is in Northeastern Province. So this is about the Nubians. Okay, as I said, they have been stateless despite fighting for the British in the First and Second World War, and then also protecting the Mau Mau fighters from the colonialists when they were fighting for independence. They actually hid them in their homes in Kibera. But once independence was gained, they became stateless. And here, the map just shows that half of them are in Nairobi, and then the others are pockets scattered all over in different parts of the country. But then, and this study was about 18,800 Nubians, all right? But for them, you can see that 63% hold birth certificates. They live in Nairobi, so which means that access to registration is very easy. But it's about the way they are treated, the way they're regarded. All right? 87% now have an ID, but this has been a long battle, and only 8% hold passports. Many of them want to go for Hajj, and they've not been able to go because they're deprived. So if they're denied just recognition, can you imagine, their health system also would not be, optimal. So when they were asked about just getting IDs, these are I'm projecting to you just their conversations about it. And one says, what? When you go, because any Nubian who wants an ID or a birth certificate needs to be vetted by a committee. And the committee there will ask them, what? Who are you? I'm Nubian. Oh, how's Sudan? Like, you're not supposed to be Kenyan. Or the other one went to a vetting manager, and when he said, I'm Muslim, he's like, oh, we don't deal with Muslims here, you know? Or they say, if you really want to get an ID, then toa kitu kidogo. You need to remove something, a bribe, all right? Otherwise, it's going to take forever. Or then they say, but I mean, you tell me how Sudan, I've never been there, all right? And then for any Kenyan who wants ID, like even my children, they just needed to get a copy of their parents' ID or birth certificate. But here they're told, oh no, you need to bring IDs for both parents, your title deed, death certificate of your grandparents, school living certificate, affidavits from the lawyer, I don't know what. It never ends. And the same people who are demanding for these documents, they don't have birth certificates of their own grandparents, nor death certificates, because certification of births was done was not done by the colonialists. It was begun after independence. Even my dad, who was, he got his birth certificate much later. And yet here for Nubians, they're supposed to produce. Yeah, so they just say that, it's a really, really difficult. It's very painful. Yeah. And basically, the Nubians don't have anywhere else to go because they've been in Kenya since like 1904. And so the roots that they had, the links they had with Sudan, where they came from, no longer exist. So where are they still supposed to go to? All right. So that is the Nubians. Any questions on Nubians? Okay. Okay. Next case study. Yeah, we had in Pumani, a hospital is a public hospital in Nairobi, and which, to me, it's a baby factory actually. But I went there for just one day to just see how it offers maternity services, and babies were just popping up from everywhere. Before you've even finished receiving a baby, the woman next to her is giving birth. So, I mean, it was an amazing experience. But in the 1970s and 80s, it wasn't like a baby factory. It was a very nice hospital, free, and and it was in a location that's predominantly Muslim. Pumani was one of the areas that the colonialists told Muslims, like from the coast, this is where you can settle. Okay, and even those from Central Province. However, they were not readily going to this health facility for some reason. I don't know. So they would go only when there was an emergency. So this woman, we're calling her Mariam, it was her first baby, and she came fitting, convulsions. And they were really having a problem controlling her blood pressure. And, her husband had married 5 times. Every time, every woman had given birth and the baby died. So this woman now, it's like she's told cesarean section is the only way we can save you and the baby. And she was refusing. She said, until the husband agrees. And the husband was reluctant to agree. So the doctor tried to convince the husband until he had to call a Muslim nurse who was off duty. She had to come to the hospital and beg and plead with the husband before he agreed, but he agreed. So at the end, they successfully delivered the woman, but the baby, the state needed, and the woman, the blood pressure was very high. It took them a month to stabilize, but alhamdulillah, they went home with a live baby. And because of that experience, then the next year, the woman came and pregnant again, this time voluntarily for ANC and all that. So otherwise, as I said, for Muslims, antenatal care is that the reasons that when I asked, why don't women come here to deliver? I mean, it's such a nice facility, it's free. And they said, oh, the nurses, when they're delivering this baby, they don't say Bismillah in the name of Allah. That, and that's what the midwives do. The extra care they give is they say Bismillah ar-Rahman Rahim before they deliver. And for us Muslims, any baby who's delivered, you need to say the adhan. The adhan is the call for prayer, Allah Akbar, Allah Akbar, and all that. And so in a public hospital which doesn't have Muslims, it doesn't happen. So for those two reasons, they prefer to deliver at home. Another reason is before they're in labor, they don't want too many vaginal examinations, or they fear they'll have male attendants examining them. So these are all Muslim-specific barriers to delivering in hospitals. So many of these women who deliver in hospitals, then those who have, let's say, retained placenta or maybe breech, or the baby, they come to the hospital very late. And so they end up getting these vaginal fistulas, they end up getting stillbirths and they end up getting PPH. So you might see the prevalence of these conditions are much higher, and these are what is contributing to the high maternal mortality rate. Okay, so that's the second case study. Okay, then we can switch gear now to curbing drug relapse in Malindi.
So there's a
Okay.
few questions actually before
Oh,
we move on.
great.
Is that
Okay.
okay?
Yes,
So,
please. Yeah.
yes. So,
Mm,
Miriam has asked, what is the
mhm.
full meaning of PPH?
Oh, postpartum hemorrhage. Sorry.
Oh, yes, yes.
Postpartum hemorrhage. CS is cesarean section. V is vaginal examination. A and C, prenatal care or antenatal care. I will
Okay.
need to remember.
Yes,
Thank you, Mariam.
and
Mm,
someone else, Shifa asked, what
mm,
type of prenatal care is available at public hospitals?
okay.
Or are there, I guess
Uh,
also, I
mhm,
didn't know if there was
mm,
other places folks could go to get prenatal care.
mhm. Uh, Prenatal care, we do have, as I said, the community health workers go make house visits, and their job is to educate the mother on the benefits and urge them or escort them to the hospitals for prenatal care. All right. And so in Kenya, what's recommended is at least 4 antenatal care visits. They call it FANC, focused antenatal care visits. So there you get HIV counseling and testing at every pregnancy. So it's not enough to say, oh, I was tested before. As long as you are negative, you need to test again. And then they also want you to bring your partner for testing. So it's not just you, but also the partner. Then there is like iron folate, because the risk of anemia, iron deficiency anemia. There is also tetanus toxoid injection, syphilis testing as well. Yeah, and nowadays they've expanded. They also do TB screening. And then in malaria endemic areas, they also give this is um, IPT, yeah, the presumptive prophylaxis for malaria. So those are, let's say, the basics that is given. So they also screen, like weight, height, to see whether, the woman would be able to deliver safely, or she needs just to be booked for um, cesarean. Also, like rhesus, negative mothers, sickle cell, all these others from history, it's included. And at the coast, they're trying to also ask about drug use, right? Because of this neonatal withdrawal syndrome. Yeah. So, I mean, these are like the package of health care, prenatal care that women are encouraged to go for. And I think there is this Beyond Zero. It's like a mobile clinic that was introduced to reach those women who can't access. But unfortunately, if you have just one mobile van for a whole county, you wonder how, and issues of fueling. So unfortunately, the idea was good, but the implementation has been a problem. All right. May I continue? Yeah.
I think so. I think there was one last comment um,
Mm.
about what is the apprehension of Muslims utilizing the hospital services. I think you went through most of that.
Yes. Yes.
So, but
I did. I did.
and
Wait, I
everyone
think I
said
have
thank you.
thank you. I think I had this sorry, this is death. There's one. Let me go back. This is pregnant. This green, the first graph, B, those are pregnant women attending 4th visit. So we can see there are some pockets. It's like 40 to below 50% in the coast and in the northeastern. And we have quite a number of very pale very pale colors, these are women who attended at least four antenatal visits. And now WHO is recommending 8, up to 8. Okay. So this is this is from the routine. And this other one on the right is also, again, 4th antenatal visit. And this is from the survey. Okay. Kenya Demographic Health Survey. So it more or less shows that there are those areas that don't attend very well. Okay, so yeah. Okay, this is a project that we had in Coast. Coast, has the high prevalence of drug use. Here we're talking about opioids. So even though the census says that Muslims comprise 11%, however, people who inject drugs, we have at the Coast, it's Muslims are 75%, 72%. All right. And then overall, among all we were implementing this medically assisted therapy program in Nairobi and in Coast region, and also in Kisumu. But Kisumu, it didn't take off very well. So Malindi Hospital is in Kilifi County, and this program was set up in February 2015. And by May the same year, like within 4 months, we had already 145 clients, accessing methadone. And methadone is like every day between 8 and 1 p.m. is when they dispense. Now, it was interesting that, as I said, 72% are Muslims, and suddenly the people who are on opioids, opioid dependent persons, suddenly they want to reform. And it's like a wake up call. Just being sober is like, wow, I'm a Muslim and I need to fast. So before, we ask them, what's your experience with fasting? And so these are the different feedback they gave us. There are those, well, me, I never fasted. As long as I was using heroin, I never fasted. And then those who are like, when Ramadan comes, I would fast, but because of arosto, because fasting meant food, drink, and drugs, and no heroin. So some is like that severe withdrawal. It's like they just had to stop. But there are those who taper. They are so conscious that despite their drug use and all that, but for them, fasting is a priority. So they taper the heroin use the month before Ramadan so that then they're able to fast easily. And then they would only smoke in the evening. Then there are those who, it's like, I never fasted, but when I was arrested for, stealing and all that, and I was locked up, is when, in prison, I was able to fast. And then there are those who just say, forget it, drug users can't fast. So what happens? So they started, as they were into the program and getting sober. Now they're like, hey, Ramadan's coming. They're beating the drums. Ramadan's coming. Ramadan's coming. Hey, we want to fast. We don't want to be on methadone. Taper us off or give us another time. And now this is something that was unheard of globally. We didn't know any program whether it's Malaysia, whether it's Mauritius and Tanzania next door, who had well-established programs. We asked them, what are you doing about Ramadan? And they're like, we don't do anything, that's not our it's not our problem. These people must comply, And but the clients here insisted. And the experts in harm reduction experts said, no, it's about structure. They have to comply, So you can't. You have to just insist that they shouldn't fast. They should be on methadone. So what happens? Ramadan starts. So what happens? We've asked the imams, and the imams say, no, it's a sickness. As a Muslim, if you're traveling, you're pregnant, you're lactating, you're sick, you're exempted from fasting. But the clients there said, yeah, you're exempted, but you have to pay. It's a debt. So if we're on methadone, for how long, we don't know when we'll wean off. Before the next year, we should have paid those 30 days fast. So what happened? Well, Ramadan came, no plan. And so the clinic is open day 1, day 2, day 3. And we noticed that there are clients who are dropping off. They're not coming, they're not coming, they're not coming. Yeah. So what do we do? Because on day 1, 28 clients out of 145 did not report for their methadone. Okay. So on day 2, there are those who had a roster 8, just came reluctantly. 20 stubbornly said, nope, we're not coming. So the next day, 10, that severe withdrawal, because they're fasting and they're not getting methadone, they came. But by then, I think we had a county health director who was fortunately Muslim. And she said, no, this is not right. So called us for a crisis meeting and said, no, we have to, support these clients. So Alhamdulillah, the Muslim staff in that team, they said, okay, we will dispense at night. So they split. They had shifts, not just Muslims, but even the others, those who work during the day and those who work at dawn, at sunset. So clients who are fasting come like 6 p.m., then they pray, and they break their fast. So every client comes to the window, is given dates, water, and their dose. And mashallah, they were really, really thankful. They prayed together and then they go. And, by the end of Ramadan, we had 44 who had fasted for the first time, something they had not planned. So this actually was replicated. So the next year we set up a program, medical assisted therapy clinic in Mombasa, and they, of course, insisted they must do the same, and it was. And so since 2015, every year, dates are mobilized, and so that the clinics can support those clients, Muslim clients who want to fast. But the service is also allowed. Non-Muslims who are not necessarily fasting but working and want to take their dose in the evening are also allowed. So that's one example of how at least their needs have been met. Curbing drug use through spiritual support was what this poster was entitled. Any questions on this or comments? No? Okay. Yeah, so the last one was Lamu and Wajir, where a colleague did a study to look at family planning uptake among Muslim communities. So they looked at perspectives from the women's side and also from the men's side. So the belief was that you breastfeed, during breastfeeding, you get a lactation amenorrhea, so you don't get your menses, so it helps in child spacing. But then, so for these communities in Wajir, they thought that by that family planning is not acceptable because according to them, they say Allah says, give birth, in numbers, plenty, that it's a blessing. And so they felt that they would be disobedient to Allah by controlling the number of children. Yeah, so that was one thing. And then here, it's like some women, it's like, oh, we want so many children, because when some die, you still have some, because we could see like infant mortality rate was higher in the northeastern region. So for them, they think it's risky just giving birth to a few. Okay. And then also the men is that they want, oh, that was in Lamu. Then the men, it's like, oh, we want our women to give birth until menopause. That's what I want. I need like around 15. For them, is Allah is the provider. So it should never be an issue that you're saying you can't take care of them. All right. So and then social cultural, like in Lamu, it's the mother-in-law who will suggest and influence, how many children that you can have. Whereas in Wajir, it's the husband, also Northeastern, where the men are the main decision makers about whether a woman should use family planning, where a woman should deliver and all that. So these are the social cultural influences that are on the health and health outcomes of Muslim women. So can I stop there and say, the questions, comments? I've tried to capture. This is actually a very deep topic, and just to make it digestible, I hope I have not overwhelmed you with too much information. Mm.
There is another question.
Okay.
Can you comment on FGM practices in Kenya?
Yeah.
Relevant.
All right. Yeah. Thank you. Yeah. So we have several ethnic groups that do practice FGM, and this is from Central
Maybe Dr. Paul was
Province.
explaining us because me and
Huh?
him we joined together the June thought.
No, go ahead. That's just like unnecessary
Uh,
background noise. Don't worry about that.
Oh, thank you. Thank you. Yeah, as I said, FGM is not just practiced in Muslims. We also have a number of non-Muslims who do practice FGM. However, the Somalis are the ones who have the highest prevalence because it's about 91, 92%. Uh, Overall Muslim prevalence is like 53, but when you look at the other Muslim communities, it's less than 10% who practice FGM. And they just believe that it is a religious obligation. Okay, it's they strongly believe that it should be done, and it's the women who actually practice. And for many of the girls who are cut, it's when they're aged below 10 years. Yeah. So the men also think, oh, it helps to keep the women, chaste. And if they're not circumcised, then they'll be more promiscuous. So, and also there is the economic factor. Those women who make a living out of doing the practice, they are reluctant. Yeah. So, I mean, they've looked at trends using the Kenya Demographic Health Survey, and they see that there has been, like, I think, an 8% decline in the percentage of, let's say, men or women who support the elimination of FGM. But however, the practice still continues to date. Yes, Dr. Cersei?
Yes, we have another question another question for you.
Mm-hmm.
It's from Miriam. I can bring her off so she can ask.
Okay. Yes, Mariam.
Okay. Yes. Can you hear me?
Mm-hmm. Yes, I do very well.
Thank you, Dr. Abdullah. For the FGM,
Mm-hmm.
as a medical doctor yourself, are there any other medical professionals in the Kenyan communities who are educating the community members, especially the men and even the women,
Mm-hmm.
that force younger girls and women into doing the FGM? Are they educating them about the what would I call it, the complications? Because there's one thing is to follow the culture, one thing is to follow the religion, which is Islam. So unfortunately, many Muslims believe it is part of the religion. It is not. It's just that culture is so steep in many African countries, and it's when culture is so steep, it's very easy to mix culture and the religion together and get them wish-washy, and before you know it, you are confused. So I think there should be education for the men, especially, who force their women, and even some women. Some women actually force the women folk, the girls in their community, to practice it. Otherwise, the girls will be ostracized. So I think African communities, especially those who are educated, and who know that this is not part of the religion. This is just a cultural act that is not healthy in the first place. And it's, well, I
True.
mean, yeah, so are there any people fighting against this cultural act that is totally un-Islamic?
Yeah, thank you. That's a very important point. Um, I mean, as I said, even problems of deliveries, the fistula, just that fistula, where a woman, because of FGM, can't deliver and gets all these damage to that perineum, and for life. Now she's ostracized. Now, because of the FGM, she's stinking urine and feces and all that, and needs repair, right? So yes, they are the Ministry of Health, the health workers on the ground, they do that, and with support of the UNFPA, right? It has tried to work with the religious leaders as well, because in the end, it's about getting those imams and um, the religious leaders of those communities to engage and to discuss what is the Islamic perspective. Yeah, that there's no such thing that that says that you must circumcise females, and especially this pharaonic type, where they cut off the labia majora and all that. It's something that everybody's striving to discourage, including the Somalis themselves. In fact, when I presented the data on the report saying it's now 91%, they called me, the Somali doctors, and called me and said, no, actually, it's actually much less than that. It's changed. It's not. So I hope so. That but I think, Mariam, what you're raising is, yeah, we need to be more aggressive in the reaching out and in working with the faith leaders to curb this practice. Yeah, because I mean the consequences are just adverse and lifelong. Yeah.
Thank
Yes.
you.
Okay.
I don't see any other
Anyone?
questions at the moment.
Okay. Well, I hope everybody has gained from this, and I hope I've whetted your appetite for my podcast series on Muslims for Health, Leaving No Kenyan Behind. We shall be zeroing in on different communities, looking at, their unique health-related needs. So what we've discussed here, the Somali perspective, is something, yeah, we will definitely address by also exploring the religion, the fatwas, because we have, like, as Muslims, we take our learnings from the Quran, the Sunnah, these are the sayings of Prophet Muhammad sallallahu alaihi wasallam, and also the fiqh, or the jurisprudence, yeah, where the thought scholars, the top scholars now, interpret everything with regards to health, and they'll give you, usually they might say, okay, there's this thinking and this thinking and this thinking, so you decide that out of these, yeah, which position you want to take, and you want to follow. But I mean, it's actually fascinating. It's a fascinating field, and I encourage everyone to, read. And I will post a lot of the references once I set up a web page on this.
Cool. And there was one other question. I don't know if
Mm-hmm,
Dr. Shafi wants to ask live, but it was
mm-hmm,
about discrimination and it being a factor in medical care.
mm,
Let me see if
okay.
he's able
Yeah.
to speak more to that question.
Mm-hmm.
But if not, I didn't know if you wanted to end on that
Yeah.
note.
Yeah. No, I mean, there is this stereotyping where some health workers who are not of Muslim faith, maybe, they do tend to look down on, let's say, Muslims. Maybe they look at them as they're ignorant or they're backwards, especially if, someone comes with, it's her 10th pregnancy and maybe she doesn't want, let's say, tubal ligation or something. So it's all about communication. Yeah. If you are negative, then of course you're going to discourage people from coming. It is there. Yeah. So these biases do exist, and I think we just need to document. But one thing is, even if you see, suboptimal birth outcomes or other for other health care outcomes, unfortunately, in our system, we don't document religion. Yeah, we just put a person's name, age, sex, location, but religion, ethnicity is not documented. I think that's where the US health system is, has an advantage. At least you do ask, is it, race, black, white, Asian, whatever. To me, that's the minimum that we need to include so that if you're now looking at those, all those maps, yeah, all those maps are just showing location. Yeah, they're just showing, okay, Nairobi is not doing as well. But in Nairobi, which communities are really affecting, because we know, as I said, Nairobi, we had a lot of in-migration. And we do know, like Somalis, many of them are moving into Nairobi. We have a lot of refugees that have now moved into Nairobi. We are now expanding registration of Somalis and no vetting. So the composition and health profile of Nairobi will be evolving. And so to me, this question of discrimination, we can't really document it well with regards to religion, except with regards to studies and there are also very many studies that may look at discrimination, but forget to put that identification of Muslims or ethnicity as one of the variables of, you know, um, analysis. Even the KDHS, Kenya Demographic and Health Survey, which looks at everything, it captures religion. But when you look at the report, they report about stigma, discrimination, but that stigma, discrimination, the religion has been dropped. So I think we'll have to do secondary analysis on that variable. Okay.
What an absolutely wonderful presentation today.
Mm-hmm. Thank you.
Yes, I cannot thank you enough. There have been many requests for your email address,
Okay,
Sade.
thank you.
Would you mind if
I will
we
share.
shared that with folks?
Please go ahead. I welcome feedback. I welcome questions and dialogue.
Okay,
Thank you very
wonderful.
much. All right,
Yes,
thank you.
yes.
Okay.
Dr. Carpenter, did you have anything you'd like to ask?
Yes, thank you all.
Say, excuse me.
Yeah, thank you all for coming. Thank you, Sade, for a wonderful and sagacious introduction to your podcast. Definitely like an appetite, for the
Thank you.
insights that you have as well. Thank you, Sabath, and thank you always, Dr. Lecomte.
Thank you.
And someone said, "That's my mom."
Yes. Thank you, Lulu. Thanks for attending.
How very sweet.
Thank you.
Yes,
All right.
yes.
Alhamdulillah.
Thank you.
Okay. Thank you,
Right.
everybody. Okay. Bye. Mm-mm. Okay.